Gentlemen, it's 16 o'clock Berlin time, and welcome to Clinical Journal Club in English. In the New England Journal this week, we see a 56-year-old woman who comes to an emergency department because of shortness of breath, non-smoker. Physical examination shows some abnormal breath sounds. She's hypoxemic, and we see this CT. And we're asked to make a judgment here. Non-small cell lung cancer, sarcoidosis, Langerhans, histiocytosis, histoplasmosis, and septic emboli. Now, we're not given a past history of fever or infection elsewhere. In this CT, we can see the pulmonary vasculature. It looks okay. What we see in both lung fields are basically multiple small nodules bilaterally. They're a little larger than I would expect for miliary tuberculosis, but that's not offered anyway. In sarcoidosis, I would expect large lymph nodes. Perhaps we don't see that here. Langerhans cell histiocytosis, I would expect pulmonary fibrosis, not so homogeneous as this, perhaps pneumothorax, something of this nature. Problems with bone disease or perhaps pituitary problems. We aren't told of these sorts of things. Histoplasmosis, I think, is a definite possibility. Septic emboli, we don't have a history of infection. I missed this one, incidentally. I didn't know what it was. Turns out this is non-small cell lung cancer, where I would actually expect a primary mass lesion and perhaps smaller metastases or something of this nature. But this is actually non-small cell lung cancer. This is a miliary form of non-small cell lung cancer. It's characterized by epidermal growth factor receptor mutations. And I was not aware of that. I have not seen that, but a search in the literature made me smarter. Here's a case report of 500 patients with this condition. We see here this transverse CT and these fairly large millet seeds. Actually, they're too large to be millet seeds, but bilateral. We see here brain metastases and also liver metastases that were reported in this patient. Apparently, this disease entity is common in patients that have epidermal growth factor receptor mutations. I would think it would have a terrible prognosis, but the authors claim that that's not the case. So we learned something there. Here's sarcoidosis, large lymph nodes in these two x-rays, diffuse bilateral disease, primarily lower lobe as shown here, but diffuse fibrosis doesn't really have this millet seed appearance. This is Langerhans cell histiocytosis, also granularity bilaterally, diffuse pulmonary fibrosis, but bone involvement, and here involvement in the cella turcica resulting in what we call Hans-Schuller-Christian's disease. Histoplasmosis, and this was endemic in Indiana, where I was on the faculty for 20 years, and these millet seeds look fairly convincing, but they're a little smaller than what we saw in the first x-ray. But I think histoplasmosis would be a pretty good candidate if the patient is from the correct part of the country. Septic emboli are not diffuse. They can certainly be bilateral as shown here, but they're more heterogeneous than the x-ray that we saw. Brain is involved and we would probably expect cardiac involvement, and we would also expect some sort of clinical manifestations of sepsis, which was not the case here. The first topic in the New England Journal is elephantiasis. This is a nematode disease induced by small worms that inhabit the lymphatic vessels of patients. It's found in Africa, Wuchereria bancrofti, but also in Malaysia, Brugia malay. The disease is transferred by mosquitoes, and it results in devastating complications in infected patients. Now, there's a strategy to try to eliminate lymphatic filariasis or elephantiasis worldwide. And this strategy involves giving large numbers of patients in certain areas of Africa or Malaysia a prophylactic treatment to try to eliminate this lymphatic filarial worm. And in this study here, there was a 2-drug regimen compared with the 3-drug regimen. The 3-drug regimen is ivermectin plus diethylcarbamazine plus albendazole. You'll recall that ivermectin and albendazole were a relatively recent topic for Nobel Prizes compared to an older 2-drug regimen. And this study was conducted in Papua New Guinea, and I think it was also groups in Africa, not quite certain, but we see here 2-drug regimen compared to 3-drug regimen, and then the clearance of microfilariae was measured in blood at 12 months, 24 months, and 36 months. As I recall, the best time of day to draw blood for microfilariae is during the night. What we see here is participants that completed this trial, and there are some significant differences here, and the 2-drug regimen resulted in a better clearance than the 3-drug regimen resulted in a better clearance than the 2-drug regimen. And that's shown here. With the 3-drug regimen, there's a crashing decrease in microfilarial count compared to the 2-drug regimen, where there are also drug failures. And at 36 months, there's a recidivism, but only in a very few patients here compared to the 2-drug regimen is shown here. So seems to be no doubt about it. After 36 months, the 3-drug regimen beats the 2-drug regimen. And adverse events, headache, nausea, and fatigue sound like if a drug's only given once a year, this sounds like it's acceptable. So this study shows that this 3-drug regimen to eliminate lymphatic filariasis beats the older 2-drug regimen in terms of eliminating these worms in sub-Saharan Africa and also in Malaysia. The next topic in the New England Journal involves myeloma cells, and to give you a little background, elotuzumab is an antibody that addresses CD319, also known as SLAM-F7. This is a molecule that's present on myeloma cells that keeps them from being attacked by natural killer cells. And the strategy here is to block SLAM-F7. Then we would expect that natural killer cells would be better at killing myeloma cells. So this, in essence, is another checkpoint strategy used for the treatment of myeloma. Now you might ask, well, why don't the people just use PD-L1 or PD-1 as a checkpoint? And as a matter of fact, I learned to my interest that that's already been done. And the antibody pembrolizumab, which is against PD-1, programmed death 1 molecule, this is also a checkpoint inhibitor strategy, has already been tested in multiple myeloma. And what we see here is no improvement with pembrolizumab. So this type of strategy, checkpoint, doesn't work in all diseases. It's effective for B-cell lymphoma and for non-small cell lung cancer, but it didn't help people with multiple myeloma. So perhaps elotuzumab is better. And in this study, in which patients had already failed previous regimens as treatment for multiple myeloma, these patients were given a thalidomide derivative, dexamethasone, plus this antibody against SLAM-F7 versus placebo. And we can look at these patients, and they've already failed all these various drugs shown here. So these are the patients with refractory multiple myeloma. And what we see here, this is progression-free survival. Now this provides no cure, but elotuzumab group certainly beat the control group, and in various subdivisions of patients with the disease, elotuzumab was better. And the Treatment response is judged by the investigators, also certainly beat the control group as shown in this table. And probability of survival, hazard ratio reduced by, this is a relative reduction of 40%. The numbers are too small to draw statistical inference, but the authors imply that perhaps this combination might improve survival in patients with refractory multiple myeloma. Adverse events, neutropenia, anemia, infections, these things were looked upon. But again, these are patients with refractory multiple myeloma, which is a lethal disease, and so any improvement would help. And I was interested to learn in the supplement that elotuzumab works absolutely fantastic in a mouse model compared to other regimens for multiple myeloma. The responses in the humans weren't quite as good, but they were encouraging, which might offer these patients an additional alternative. The next topic in the New England Journal has to do with nutrition in patients that are critically ill. And we're aware that patients with critical illness have a high caloric requirement. However, incorporating these calories and doing something with them is another issue. So what was done here in this particular study, patients received an energy-dense, and I'm talking about calories here, not about protein calories or lipids, I'm talking about carbohydrate calories, energy-dense regimen versus usual care kind of enteral nutrition that we apply for patients in the critical care unit, randomized to these regimens. And in terms of testing the hypothesis that improved nutrition might improve outcomes or survival in these patients. And if we look at this, the first thing that we're interested in is, did the people actually deliver these kilocalories to these patients? Indeed they did in terms of calories delivered, trial nutrition versus, in essence, it's a 30% increase in caloric intake in these patients, and that was achieved, although protein intake was held constant, which is generous anyway. And what we see here is good separation of the two groups, the high calorie group versus the low calorie group, all the way around. So the experimental protocol functioned, but what we see here is, if we look at these hazard ratios, absolutely no difference in survival, death at day 28, mechanical ventilation, vasopressing support, or all the other things that we look at in patients that are critically ill. And here are the groups, absolutely no difference between 1.5 kilocalories or 1.0 kilocalories. And looking at subgroups, too small to make inference where outliers such as this one occur, but there's no suggestive evidence that some subgroups might have benefited from this treatment, which was delivered here. So this study gave a negative outcome, implying that perhaps this strategy is a failure and the routine therapies that we currently employ are as good as we're going to do. The next topic in the New England Journal is gonorrhea. This is rather a distasteful topic, but unfortunately this is a very common infectious disease in men and women that, in addition to causing urethritis and problems associated with the urogenital tract, can also cause sepsis, septic arthritis, and conjunctivitis of the newborn. When I was in medical school, there was a cure for this, and that was penicillin, and the disease was gone within 4 hours. Now, life doesn't stay simple, and N Neisseria gonorrhea has developed resistance against various antibiotics, and currently antibiotic resistance against gonorrhea makes this a disease a major health problem, and the incidence unfortunately is rising. So in this study, a new strategy, zoliflodacin, which is a DNA gyrase inhibitor of bacterial DNA, was tested against ceftriaxone. Single dose, sounds appropriate, oral, also convenient to give, compared to 500 milligram intramuscular dose of ceftriaxone. and this regimen was given to various patients that are shown here in the table. Looking at microbacterial cure rates, okay, the ceftriaxone still looks pretty good, but zoliflodacin was also successful in certain groups, urethral and rectal disease, somewhat less successful in pharyngeal disease, and these differences are shown here. Adverse events, moderate to serious events are recorded. One patient suffered a non-fatal gunshot wound, but the investigators decided that the gunshot wound was probably not related to the antibiotic regimen. Everything has to be reported in the United States. And so here's the comparison. I think we can summarize this up. Zoliflodacin was effective against fairly straightforward simple gonorrheal, urogenital, and rectal infections. It was less effective in pharyngeal gonorrhea and in more complicated disease. But it looks that as though this antibiotic may have something else to offer patients with gonorrhea, a disease that 30 years ago was invariably effectively treated by penicillin, which is no longer the case. The next report in the New England Journal concerns allogeneic bone marrow transplant, and HLA matching is done to the best of available donors, but one common complication is the development of antibodies against blood groups, so that transplanted patients become profoundly or severely anemic, and these antibodies can be measured. And what was done here, just out of the box treatment, what employed here is a treatment that's usually given for multiple myeloma, an antibody against CD38, which is expressed on myeloma cells, but also on plasma cells. The idea here was to perhaps hit the clone that's producing these antibodies. And it's a brief report, but what we see here with the administration of daratumumab in the patient shown here, there's a marked increase of hematocrit to normal levels and a decrease in antibody titers. So it looks like this antibody, actually a drug that was developed for multiple myeloma against CD38, might help these patients with red cell aplasia who develop anemia after allogeneic bone marrow transplant. Now, the review in the New England Journal is also a depressing topic. It concerns ethical problems in neonatal intensive care units. And one of the patients that are perhaps a background for this particular review is this patient. This is the Charlie Gard case. And this is a tragic patient in a neonatal intensive care unit that has a genetic disease that involves mitochondrial DNA. This is the mitochondrial DNA depletion syndrome, a rare genetic disorder that causes progressive brain damage and invariably leads to death. This patient was in an intensive care unit in London, the Great Ormond Street Hospital, abbreviated GOSH. So this patient was hospitalized in the GOSH. Doesn't look much better than the hospitals that we have here. There's a person in New York, Dr. Hirano, who claims that he has a treatment for this rare condition. He was even invited to London to treat this child. The National Health Service agreed to pay the fee. He didn't show up. The patient was declared terminal. The staff wanted to repeal medical care and in essence, let him die. The parents of the patient took him to court. The British courts sided with the doctors. This case was eventually brought to the Court of Appeal of the European Court of Human Rights. Must have been before the Brexit. In other words, this thing ended up being a legal disaster. And the review concerns strategies to perhaps improve communications so these kinds of disasters are avoided. So the review involves ethical problems and decision-making in the neonatal intensive care unit, because once lawyers and courts are involved, physicians are relegating their responsibilities to attorneys, which is, in terms of healthcare, a very inferior strategy in my view. And so the discussant here stresses communications with parents and giving a realistic but nevertheless still perhaps optimistic approach rather than just pulling the rug out from under these patients and removing all hope, and in terms of the care that has to be rendered. And most of the disagreements are not necessarily related to doctors withholding bleak information. Patients require honesty, but they also would like to have some hope for some sort of options if this is possible. Then there are some case presentations here. Young person, newborn, that has pulmonary and intraventricular hemorrhages and is severely retarded, and actually life support should be withdrawn. And the discussions with the parents involve things like, will I be able to love him even if he is handicapped? And the doctors give a reassuring answer, and the discussions involve issues of this nature. And a second case was called example shown here. And if you're involved in intensive care medicine, these are important issues, not just for neonates, but for adults as well, to try to help relatives deal with this problem, with these kinds of problems, in a framework that hopefully keeps the courts out of it. And that is the discussion in this review. Then there's some case reports. This poor woman comes to an emergency room after landing in an international airport and claims that she swallowed 30 packs of opium. A CT is done, and indeed, she has packets in her large intestine, and they're very radiodense. And so she's given polyethylene glycol by mouth, obviously, and she expels these packets, and they're laced with lead, which the dealers then use as a leverage to sell this material to the junkies. And since it's sold on the basis of weight, that's the purpose of the lead. And we already looked at the consequences of this strategy last week, where this patient who's been taking opium for years develops these lead lines. So that's something to know, that you need to know about if you deal with these patients. Then the patient of the week in the New England Journal, rather difficult patient in my view. It's a neurological case. This is a 58-year-old woman who suddenly develops numbness and tingling in her left foot, and she develops weakness in her abdominal wall that is severe enough that she's not able to rise to a sitting position. She's got a history, which I thought is surprising for a 56-year-old woman, of having been operated on for spinal stenosis at a fairly young age. An increase in blood sugar is observed, suggesting that she has underlying diabetes mellitus that might play a role in this neurological syndrome. And as an aside, she reports that she had some sort of a rash, 8 centimeters in diameter, on one gluteal fold, that she thought might be subsequent to some sort of an insect bite. That was present in the text of this report, but sort of an aside comment. We see an MRI, and you can read the interpretation here, but basically the MRI was declared to be negative, so that cord signs were not held responsible. Cord compression was not held responsible for this syndrome, and by neurological examination, long tract signs were also not present. So the neurologists interpreted this constellation as representing a radiculopathy, and then the discussion goes, what could cause a radiculopathy in this patient, and what would be responsible for weakness of abdominal musculature, and diabetes is discussed here in some detail because of the elevated blood sugars in this patient, which is possible. And then inflammatory polyneuropathies are also discussed, and cancer and neurosarcoidosis, and also infection. And that brings up again the story of this rash and whatever that might have been. And one cause of poly-radiculitis is Lymes disease, which generally also is known for cranial nerve palsies and other things that we think about when we think about neurological Lymes disease. So that possibility was entertained and antibodies were measured, and indeed this patient has neural Lyme disease. And her rash was not shown in this report, but the internet gives us a handy array of different rashes that are associated with Lyme disease that you can show your patients when you have them, to ask them, did your rash look anything like this? Because when this patient presented, the rash was already long gone. And I was interested to observe that in the German Medical Weekly, the Deutsche Ärzteblatt, in this issue, the last one that came out, indeed, neural Lyme disease is discussed here. And one of the differential diagnoses is radiculitis, which fits for this patient's constellation of symptoms, which would prompt an antibody diagnostic to see if this is indeed the correct diagnosis. Now we move to the Lancet, which was also pretty busy this week. The whole issue has to do with the global burden of disease study. And I don't mean to beat you to death with this topic, but it's fairly important. And the global burden of disease is a worldwide investigation, largely funded by Bill Gates and his wife. What's concerned here is what are the causes of death and what are the risk factors and how many disability adjusted life years are lost in all of the countries worldwide. And one of the variables that they have coined in these studies are the so-called socio-demographic index, which is a summary of socio-demographic development. In essence, it asks the question, are you rich or poor? Are you educated or not? Or did you have a whole bunch of children or only a few? And so if you get the highest possible score as you're rich, you have a doctoral degree, and you have no children, then you get a 1. That's the highest score. If you're poor, you didn't go to school at all, and you have 10 kids, you get a 0. So this is how this is scored, in case you're wondering. The first study, I'm only going to show 3 of these. There are about 8 of these papers in the Lancet. I can't show them all because I don't understand them all, to be honest with you. The first one has to do with global, regional, and national age-specific mortality and life expectancy in all the world's countries, characterized from 1950 to 2017. So this is a mouthful, and there's a lot of data here. The first thing that the authors ask is, are our data any good? And it depends on where the data come from. If the data are from high-impact countries, the data are high-income countries, the data are probably good. If the data are from sub-Saharan Africa, the data are probably not so good, and other areas of the world fall in between. And if we look at this, this is not surprising. I'm interested to see, particularly interested in my age group, 75 to 79. And what we see is that over the years to 2017, there are more of these people around than there were in 1950. And 90-year-olds, there were hardly any in 1950. Now there are at least some. Now, in early neonates, there are a lot of those, but they, at least in the first few years, they have a relatively high mortality. But then that levels off, and what we see is that the number of people, deaths depend upon how old you are, but the total number of people around increases all the time. So that the mortality rates, irrespective of age group, the mortality rates in all age groups has a downward trend. I suppose that's good. I think it's good. Now the mortality rates, mortality in newborns and young children is still high in many parts of the world, but once you've made it to 10, your outlook is pretty good. So we can expand this area here and look at all the different 1950 compared to 2017, and we're doing better in 2017 than we were in 1950. So life expectancy at birth is going up, even in the poorer countries, although there are some blips here. And then there are maps, and you can imagine that rich countries do better than poor countries, and you can look at these maps, and they're fun to look at, differences in life expectancy. Now, I was interested in looking at the Tagesspiegel. That's the Berlin daily paper. And I saw it today, and people in the Tagesspiegel even read this paper. And the issue here is Germany does worse than France and Greece. Well, that's the same as the football results that we had this summer. But I'm glad to say that the differences are slight. So that's the added value of this study. The next study that we're going to look at is, and this one's important because it has to do with 84 behavioral, environmental, occupational, and metabolic risk factors. And have things changed since 1990 to 2017? So this is important. And the usual risk factors are blood pressure, smoking, fasting glucose, being obese, small for gestational age, and what have you. So here we have this socio-demographic index. Some of these I understand and some I don't. Now, if we're rich, then unsafe water sources are not terribly important because we don't have those. If we're poor, that's a problem. Household air pollution, aside from diesel automobiles, is also distributed in the same way. Some of these things are across the board. Blood pressure is bad if you have a socio-demographic index that's terrible compared to if you have a social demographic index that we would find preferable. Seems to play a little role. Blood pressure is bad across the board. Smoking, you have to have money to buy cigarettes, I guess. Depends. That's sort of variable, and you can look at these things and make your own judgment on them. And here, if we look at these tables, how is it for everybody? High blood pressure is number one. Smoking is bad for you. High glucose, the usual suspects. There's some slight differences in men and women, but matters have changed pretty much the way they were. Blood pressure and smoking still head the list. And you can look at these variables in terms of graphics that are shown here, percentage change over some of these things over time, and then there's some fascinating maps again, population aging all over, sub-equatorial Africa, aging less so, people still die at a younger age, and you could look at all the countries of your choice, and I've forgotten what some of these abbreviations stand for, but you can look at those. And this lovely diagram here, I copied it because it's so aesthetically beautiful, but I'm not quite certain what it means, but I'd encourage you to look at it because it tells you what the daily loss in functional life years are for these various risk factors across the board. Lastly, population and fertility by age and sex. That's also an important topic. Fertility rates are decreasing, but since the population has doubled since 1950 from 3.5 billion to 7.5 billion, the number of women of childbearing age has also increased remarkably. So if their fertility has dropped in half, doesn't help that much because the population is still going to increase at a substantial rate. But at least fertility seems to have decreased, at least in some parts of the world more than others. And you can look at these various age groups that are involved here, and it's pretty much the data as we would expect them. And you can also look at these interesting colorful maps here. But population size and age structure have substantial consequences. We can expect this, but strategies in terms of how to deal with this problem weren't all that forthcoming in this global burden of disease study. Perhaps Bill and Melinda Gates will address that at some future date. Now, returning to clinical medicine, I was interested in a couple of topics here. One of them has to do with DPP4 inhibition in terms of treating type 2 diabetes. You'll recall that this dipeptidyl-peptidase is the enzyme that metabolizes glucagon-like peptides, which stimulate insulin release and inhibit glucagon release. So in essence, inhibiting this enzyme should improve the effects of GLP-1 agonists that we discussed last week. And in this large randomized controlled trial, a DPP4 dipeptidyl-peptidase 4 inhibitor was tested in a large number of type 2 diabetes patients, over 3,500 in each group, to see if it would reduce cardiovascular events. Hemoglobin A1C was reduced, but cardiovascular events were not reduced by this strategy, which is opposed to results from studies that involve GLP-1 agonists by themselves. You would think that perhaps a combination of these two strategies might be best to make the patients. See if I can get... Then we're left with the question of the week in the New England Journal. What's the most important step for a patient who's a heavy smoker and he has a 2.5 centimeter solitary pulmonary nodule, and you're offered obtain sputum for tuberculosis and culture, refer for transbronchial biopsy, obtain sputum for cytology, refer for CT-guided transthoracic biopsy, or refer for surgical incision. I think in most hospitals, all of these things would get done because there's a profit motive, of course, in hospitals. But here, Murphy's law of going where the money is the best strategy. So we refer this patient for surgical excision because transbronchial biopsy isn't going to get this lesion, and CT-guided thoracic biopsy might, but if it's negative, you have to do a surgical incision anyway. And if it's positive, you're still going to do a surgical excision. And I put this question up because of this review that was present in JMA, and it has to do with pulmonary nodules. This time not in normal chest x-rays, but instead in CTs, and how to deal with them in terms of a strategy. And it depends upon size and which nodules can be treated with observation and which should be addressed immediately is the discussion in this particular review that you can have a look at if you deal with CTs and this kind of decision making. Finally, we have a 37-year-old female patient, a 37-year-old woman referred to a rheumatology department, not quite sure why, but she's got rib pain. And the thought is that this might be costochondritis. Somebody measured serum phosphate, very clever thing to do, and her serum phosphate level is 0.5 millimoles per liter. And a common response here, instead of working this up properly, is just to give these patients vitamin D. That was done to this patient also, but vitamin D didn't help the situation. Then somebody measured transtubular phosphate reabsorption, and the patient has profound phosphaturia, which raises the possibility that this might be in fibroblast growth factor 23 syndrome, which is a hormone that's produced by bone, which results in phosphaturia and suppresses vitamin D synthesis. And an appropriate workup was done, and she had a tumor that produced FGF23. So you should be able to conduct a reasonable diagnosis on persons that have hypophosphatemia, and the response shouldn't be merely prescribing vitamin D, but instead it should involve looking at phosphaturia, tuburophosphate reabsorption to see if that's appropriate, and the measurement of FGF23 and conducting further studies to rule out a tumor if that's the question. Thank you very much for your attention. That's it for English. If you're interested in German, I'll do the whole thing over in 20 minutes, and otherwise see you next week.
Wenn du die abends wieder nicht mehr los ist.
Aber es